We'll talk about cardiogenic shock. Now, just need here. I have no conflicts of interest. Now we're talking about a small subset of the AMI patients. And if we take STEMI patients, it's actually 1 in 10 that get cardiogenic shock. The 9 other people, they actually do well today due to the good treatment, good invasive treatment, good medical treatment. But the one who developed cardiogenic shock, that's where all the problems is. And if you take them, actually only half of them survive the hospital. So they have a 50% mortality. We know from 25 years ago that we should try to early revascularize these patients. This is an American trial, only 300 patients. This is what we base the cardiogenic shock recommendation today, to immediately revascularize these patients. And Holger Thiele from Germany have shown us that when you get a patient with cardiogenic shock into your cath room, please only do the infarct-related artery. Full revasc will be done later. So focus on that. But then it becomes very difficult with the rest of the documentation. We don't know which vasopressors we should use, and we don't know which inotropes we should use. There are very few studies, and they really don't show superiority among each other. And I would also say the balloon pump was taken out of this cardiogenic shock due to myocardial infarction 12, 13 years ago by Holger Thiele. 600 AMI shocks randomized here, no effect of the balloon pump. And very recently, in patient who did have shock but not an AMI, actually it was also neutral. So the balloon pump does not work in this acute setting. So we are left with the ECMO system or the impeller system to try to stabilize these very sick patients. Holger Thiele's group showed us 2 years ago where he randomized 420 patients to either medical treatment after the PCI or ECMO when they were in shock. And as you see here, this is from the supplement, there was no effect on the lactate clearance, and there was no effect on survival. So ECMO did not help these patients with AMI and cardiogenic shock. But 78%, almost 4 out of 5 patients, actually had an out-of-hospital cardiac arrest. So this was mainly a trial in patients who had a cardiac arrest. It was not sort of the awake cardiogenic shock. And I think this is important because for once they can have a brain damage, which the ECMO will not help on. And for 2, these cardiac arrest patients may look like cardiogenic shock even though the circulation is okay. So this leaves us with a situation of the cardiogenic shock population here. They can have LV failure, right ventricular failure, and then there's something about the cardiac arrest that makes noise around it. And we did a trial over the last many years called Danger Shock trial, where we tried to see if the microaxial flow pump called impeller worked. And the way it works is that it actually sucks blood out of the left ventricle and pump it up into the aorta here. But we only looked at those who had LV failure and no cardiac arrest. And when we did that, by including STEMI patients who were in shock, but we excluded all out-of-hospital cardiac arrest. So we focused on the patients with just cardiogenic shock and STEMI. And what we saw when we took that population, we saw that it actually increases the lactate clearance. The lactate gets faster out of the body. And we also saw that we use less vasopressors, less inotrope because of this mechanical support. And this is very interesting. We saw published at ESC meeting a month ago, that the impeller, which can pump 3 liters per minute, actually did not increase the cardiac output. This is the top part of the figure here in the first hours, but it unloads the heart. It reduces the left atrial pressure. It reduces the pulmonary pressure quite a lot. So it's unloading the left ventricle, doing the work for it, but it does not increase cardiac output by itself. The primary endpoint of this trial, and I have a picture here of my colleague who did all the hard work with the trial over the many years, Jacob Muller, showed with a very high mortality in the control group that it actually improves survival. You take these cardiogenic shock patients, no cardiac arrest, and the number needed to treat to save 1 life was only 8 patients. This was published last year. This was this part of the figure here. You see the first half year, the 2 curves split. This year at ESC, we published the follow-up, and it lasts for many, many years. So it actually proves that if you get them through the cardiogenic shock phase, they actually do quite well. Let's do some post hoc analysis of this trial. There's a lot of, most of the subgroups seems to be okay in this danger trial, but let me focus on sex and age. I'll just give you, there's only a few females in this study, but it seems that it didn't work in the females. But when we dig down to that, it's actually because the women come later to the hospital, they stay home, they don't feel well, but they don't call for help. So they stay home longer. And as you can see, they were also about 5 years older when they get their cardiogenic shock due to the AMI. So it could be that the reason is that they were too old and stayed too long at home before seeking help. And when you look at the age, we include everyone in the danger trial that came in. The oldest patient was 93-year-old. When you look at this, when you take the 3 lower quartiles, there was an enormous effect of the impeller. But when you look at the upper quartile, those above 77 or above 80 years, you actually seems to do harm even. So consider the age of the patients when you're dealing with this, because it comes with a lot of adverse events. There's bleeding, there's limb ischemia from the femoral artery, renal replacement during the ICU period. There were no patients on dialysis 6 months out, but during the hospitalization phase, you have a lot of complications, so it may be difficult in the elderly too. But this is something that I think we can improve and do better later on, so this is good. This leaves us with a question, because now we have ECLS shock with ECMO, where it did not work. Of course, there were all these cardiac arrests. And then we have the danger study with the impeller that works. So is it because of the patients, or is it because the machine is different? And in order to try to find out about that, I, together with Holger Thiele and some other authors, collected individual data from all the trials that has been published with randomized trials on mechanical circulatory support. This figure shows that it is dominated by the danger trial and the ECLS shock, but you see we took in all the other studies too. So we combined all these individual data and we secured 6 months follow-up on all of them. So now we have more than 1,000 patients randomized to either medical treatment or a machinery. And even though we have 1,000 patients, it's not clear that mechanical circulatory support helps these patients. There is a lot of cardiac arrest in this group. So if we only took the 589 patients that did not have long cardiac arrest and all had STEMI, then we see the same effect that we saw in the danger trial. So I think if you have an awake patient who is in cardiogenic shock, you should really consider to help him or her with a device. So to sum it all up, I would say that the routine use of an impeller on top of standard medical care reduce death from any cause in patients who have STEMI and cardiogenic shock, but you have a lot of adverse events. You have a lot of bleeding and you have ischemia from the legs, which gives problem during the hospital admission. I don't think we can extrapolate these data from other causes of cardiac arrest or cardiogenic shock. I mean, patients with cardiac arrest, you cannot just extrapolate, and you cannot extrapolate to other causes of cardiogenic shock. So it's just the STEMI with cardiogenic shock and no long-term cardiac arrest. I think that's the population where we should say that this really helps. But even if you treat these patients, they still have a high mortality. You saw that almost 50% mortality was still there. So there's still a lot to do. So this raises the question at the end, should we use it in all patients with STEMI and cardiogenic shock? Should we really use this impeller? From a scientific point of view, this is what the trial data shows. If you have STEMI with reduced ejection fraction and low blood pressure and high lactate, and they're not in coma, if you have them, the scientific data say that you should use it. But I think we could also be prudent here and look at the post hoc analysis and say, from a clinical point of view, we're all doctors when you stand with this patient. You have to consider also the age. I did not show the rest of the science here, but comorbidity matters. It works best in those who have little comorbidity. Time since first symptom, if it's more than 10 hours, the benefit seems to be very small. This is post hoc. And if they are very much in shock versus those that you can actually go through with a little norepinephrine, what does the angio say? So from a clinical point of view, I think you can be a little restrictive, but remember that the treatment is there. And this can really do something for mortality in ACS. Now we have elegant PCI opportunities. We have very good medications. So those who do not get shock, they have a very good prognosis nowadays. This is the group that really needs extra attention. I will end my talk here, but I actually, since I have 2 more minutes, will just do a little advocation for the next ESC meeting we have. We focus a lot in AI here, and I could understand from the morning session here that you also focus a lot of AI here in China. And we have actually in a month or so in Germany, we have a digital and AI summit, and you can still join if you want. Just thank you very much.